Okay. Whenever you can. Just, hey, Steve. Good morning. Good morning. Welcome to the Ahmed Glaucoma Valve Breakfast meeting. We're very pleased and happy that you're here. I hope you can all find your seats while I make a few introductory comments, but I'd like to get started on the program as soon as we can this morning because we have a really outstanding program for you. And I think it will contain some information that you will be keenly interested in at this point in time. I'll start just for a few minutes to say a few comments to set the groundwork here a little bit. We all recognize that the purpose of this is to try to provide some information and promote discussion about the implant, glaucoma drainage implants in general, and Ahmed glaucoma valve specifically. We also recognize that there are varying experience levels here. We have some truly world-famous experts here that we acknowledge and recognize and welcome, of course, because they can enrich our experience here. And we also have people that are just starting to put in the implant, and that's a good thing too. We want you to get some basic information as well that can help you get grounded about how to start off successfully with this implant. So recognizing that, I'm just going to start off with a few very basic things and maybe try to tie it into the program a little bit. So the indications for the implant are if conventional surgery fails, clearly if we have extensive limbal scarring, let's say that a patient has had a failed trabeculectomy and there's not much conjunctiva left to work with, clearly drainage implants become an attractive option. Another category that's interesting is when surgeons believe, it's primary surgery, but surgeons believe that conventional surgery, let's say trabeculectomy, is likely to fail, and that may be the instance with neovascular glaucoma or active uveitic glaucomas. Patient hasn't had surgery, but they may fail trabeculectomy if you go that route. So here's another indication for implants. And then finally, primary surgery, and that's a very interesting category that Dr. Gedde will talk much more about, and so I'm going to defer that discussion to him. And I personally am looking forward to his comments about that. Just another basic slide. This is a really old slide, but it still pretty much, I guess, summarizes the kind of result you might expect to see. Lowering of the pressure, even in refractory glaucomas, avoidance of hypotony at day 1 here, and then an increased intraocular pressure during the early postoperative period, leveling out. There is a tapering off that occurs over a period of a number of years that's been observed for a long time. We haven't analyzed it very much, and I know this was observed in Dr. Boudenz's ABC study and also Dr. Gedde's TVT study, where there's this kind of the 1-year results are a little higher than the 3-year results, or the 4-year. There's just a gradual slight increase very frequently, but it hasn't been really looked at very much. But it's usually in the mid-teens or so that we end up with our pressures. And the advantage, of course, is a lower rate of complications, fusions and hypotony, and also other vision-threatening complications compared with other implants. So implant plate design is currently a hot topic. With the gold standard, if you will, is the FP7, which is a silicone plate that has established efficacy and safety. There is, however, the new model M4. There's a lot of excitement about this. It's essentially a MedPore type of implant. It's a porous polyethylene design. The gross surface area is 191 millimeters squared, but of course the theoretical surface area is much higher. How much higher, we don't know, but it's much higher. It's hard to calculate because the pores give it a much greater surface area, and it's actually very difficult to calculate exactly how much surface area really is there. But Dr. Moster will talk much more about this, and I think show you some really exciting videos about that too. So what I'd like to do is get our speakers started. I'm really excited about this year's program. Our first speaker is Dr. Stephen Gedde, who's a professor of ophthalmology at Bascom Palmer Eye Institute, University of Miami School of Medicine, and he'll be speaking about primary surgery with drainage implants. And I'm sure that all of us will learn a lot from this presentation. So, Dr. Gedde, thank you for being here.
Thanks very much. I'm delighted to be here. I want to thank Peter for inviting me, and thank Dr. Ahmed and New World Medical for hosting, sponsoring this breakfast meeting. I was asked to discuss primary surgery with drainage implants, which I think is a very interesting and provocative topic. I have no financial interest in the subject matter of this presentation. My financial disclosure is shown here. We're seeing some interesting trends in glaucoma surgery over recent years. This is data that was provided by Bill Rich at the Academy. And you can see during this 17-year period, there's been a steady decline in the number of trabeculectomies performed in the United States. That's probably related to advances in medical therapy in the mid-1990s was when prostaglandin analogs were introduced. But what's interesting is during the same time frame, the number of tube shunts that have been placed has been steadily increasing. Now you'll note the scale is different for both these procedures, and trabeculectomy continues to be a much more commonly performed surgery than tube shunt surgery, but the shift in practice patterns I think is quite evident. Here's some additional information demonstrating this trend towards an increasing use of tube shunts as an alternative to trabeculectomy, and it involves sequential surveys of the American Glaucoma Society. The survey was first distributed by Phil Chen in 1996. It presented several clinical scenarios to AGS members and asked them what was their preferred surgical approach. And you can see in 1996, the vast majority of surgeons preferred a trabeculectomy over tube shunt surgery. The same survey was redistributed in 2008 by Manishi Design. You can see the tremendous shift towards greater use of tube shunts relative to trabeculectomy in each of these categories. So overall, there was a roughly equal split in selecting tube shunts and trabeculectomy, and that's a marked difference from 1996. The 2008 survey also included one extra question, and that was, what's your preferred initial incisional glaucoma procedure in a phakic eye with primary open-angle glaucoma? And you can see the vast majority of surgeons still preferred a trabeculectomy, usually with an adjunctive antifibrotic agent, but fully 11% of cases were being done with a tube shunt in this low-risk type of patient. And this, again, was 5 years ago. I suspect that number would be even larger today. As you've heard from Peter just a moment ago, drainage implants have historically been reserved for eyes at high risk for failure with standard filtering surgery, and that includes eyes that have extensive conjunctival scarring, usually from prior surgery, although trauma and certain cicatrizing diseases of the conjunctiva like Stevens-Johnson syndrome and ocular cicatricial pemphigoid can do this as well. Certain secondary glaucomas that are high risk for filtration failure, including neovascular glaucoma, uveitic glaucoma, ICE syndrome, fibrous and epithelial ingrowth, and aphakia, especially requiring a contact lens wear. So these are the high-risk cases that, again, traditionally have been reserved for glaucoma drainage implant surgery. You know, the TVT study showed that drainage implants are a very viable treatment option for eyes that have had prior cataract extraction or failed filtering surgery. And these eyes might be considered at intermediate risk for failure. And as we just heard from the recent AGS survey, many surgeons are considering this as a primary procedure in low-risk eyes, like eyes with primary open-angle glaucoma without previous surgery. And there's good evidence to support the use of drainage implants as a primary procedure. Tony Maltino and his colleagues in New Zealand did a study in patients with primary open-angle glaucoma without prior glaucoma surgery. Now, some of these eyes had prior cataract surgery, but none had prior glaucoma surgery. It was a prospective, non-randomized comparative case series that involved 718 eyes that had trabeculectomy, usually in the vast majority of cases without an antifibrotic agent. In fact, I think only 2% of these eyes had either mitomycin C or 5-FU. And there were 260 eyes that had a Maltino implant, either a single plate, double plate, Maltino or a Maltino 3 implant. And it was a long-term study with a mean follow-up of 7.7 years. Using survival analysis, the cumulative probability of successful pressure control was higher in the Maltino group compared to the trabeculectomy group, using criteria to define successes of pressure less than or equal to 21. When more stringent pressure criteria were used to define success and failure, there was no significant difference between the two treatment groups. Roy Wilson and his colleagues did the first randomized clinical trial comparing tube shunt surgery to trabeculectomy. He studied patients that had primary open-angle glaucoma or primary angle closure glaucoma without any prior ocular surgery. Patients were randomized to receive a S2 Ahmed implant or a trabeculectomy with or without an antifibrotic agent, depending on the surgeon's judgment. They reported a mean follow-up of 31 months in this study, and it was conducted at one clinical center in Sri Lanka. And here are the results. You can see there was a significantly greater pressure reduction in the trabeculectomy group during the first year of follow-up, but after that time, there was no significant difference between the two treatment groups. And the cumulative probability of success was the same with both treatments during the course of this study. Well, the TVT study is another randomized clinical trial comparing a tube shunt and trabeculectomy, but in a different population. These were patients that had prior ocular surgery, either prior cataract surgery with an intraocular lens implant or failed filtering surgery, and enrolled a total of 212 patients, 107 that received a 350 Beervelt implant, and 105 that had a trabeculectomy with mitomycin C. A standard dosage of 0.4 milligrams per milliliter for 4 minutes was used in this study. We've reported results through 5 years of follow-up, and there were 17 clinical centers in this study. There was significantly greater pressure reduction in the trabeculectomy group compared to the tube group during the first 6 months of the study, but after that time, there was no significant difference between the two treatment groups. And you'll note that the pressure settled in the low teens through the 5-year duration of this study. Using Kaplan-Meier survival analysis, the cumulative probability of failure was significantly higher in the trabeculectomy group compared to the tube group throughout the 5-year durations of the study, using the primary criteria for failure, which was a pressure above 21 or failure to reduce the pressure by 20% below baseline. We did several post hoc analyses to see if the results would change if more stringent criteria were used to define success and failure. And you can see there was still a significantly higher failure rate in the trabeculectomy group compared to the tube group across these different success criteria. Early postoperative complications, defined as those occurring in the first month after surgery, were significantly higher in the trabeculectomy group compared to the tube group, although late complications occurring after a month, and perhaps most importantly, serious complications occurred with similar frequency between the two study groups. Patients in the TVT study were stratified at the time of enrollment into 4 groups based on their qualifying surgery, and this was with some presumption about the risk of failure. And the stratum 1 were eyes that had only prior cataract extraction, and in many cases that was just clear cornea cataract surgery. This comprised about half the patients in the TVT study. What is interesting to me is the greatest difference in success rate between the tube group and the trabeculectomy group was actually observed in this stratum. And it was this observation that, in particular, the group of patients at lowest risk had the greatest treatment benefit of tube shunt surgery compared to trabeculectomy. That served as a major stimulus for another multi-center randomized clinical trial, which is ongoing, and that's the primary tube versus trabeculectomy study. This is a study that is still enrolling patients without prior incisional surgery that are at low risk for filtration failure, patients with primary open-angle glaucoma, pigmentary glaucoma, pseudoexfoliation glaucoma. And these patients are randomized to a 350 Baerveldt or a trabeculectomy with mitomycin C, a lower dose than was used in the TVT study. There are 16 clinical centers in this study, and we are 92% of the way to our enrollment goal of 242 patients. So hopefully this study in the not so distant future will have some additional information that will be valuable to guide surgical decision making. So in conclusion, the popularity of glaucoma drainage implants has unquestionably been growing in recent years. That's obvious from examination of Medicare claims data, surveys of the American Glaucoma Society. Implants have traditionally been reserved for eyes with refractory glaucoma at high risk for filtration failure, but the indications for using the devices are expanding to include actually low-risk patients and potentially as a primary procedure. And I think randomized clinical trials actually support this expanded use of glaucoma drainage implants and consideration as a primary procedure even in low-risk eyes. So thanks for your attention.
Thank you very much, Dr. Gedde. And I'm going to ask everybody to hold their questions. That was a very thought-provoking presentation, but hold the questions. We'll have a discussion section at the end. Well, now it's really my special pleasure to introduce Dr. Marlene Moster. She is a renowned expert in this area and also professor of ophthalmology at Wills Eye Institute, Jefferson Medical College in Philadelphia. Of course, most of us know that. She's a very well-known surgeon. So, Dr. Moster, it's really a pleasure to have you here, and she'll be speaking about the new M4 implant. Thanks.
Thank you, Peter. Good morning, everyone. It's really a pleasure to be here. I'd like to acknowledge my co-authors here, that is Victor Civital and Tim Sullivan, who are instrumental in helping with this data. Now, why should we consider the new M4 Ahmed tube shunt, as we have so much experience with the FP7 and prior iterations? The reason being is that this has a sleek design. It can be placed without mobilizing a lot of conjunctiva, has a relatively low profile, and because of the porous nature of the plate, the tissue becomes incorporated quickly, so a capsule impeding flow does not have a chance to really form. Now, why are we looking for more reliable tube shunts? The reason is tube shunts still fail. And when they do, we've already used up so much real estate. And there's a lot of chair time when the pressure is either too low or too high. And I myself have very little patience for this high pressure phase, which in my mind may lead to early failure. The perfect scenario would be a one-quadrant easy access, pressure between 8 and 18 on the first day, a rare shallow chamber, a tube that functions even in the presence of a significant hyphema, almost no need for meds, and true success moving forward. So what is the data for the old model tubes, and why are we trying to keep making this better for all of us and all our patients? If you look at the Ahmed versus Baerveldt study, where they defined failure as pressures of greater than 18 and less than a 20% drop in pressure over a 3-month period, they found at the end of 3 years a 49% reduction in pressure with the Ahmed, a 55% reduction with the Baerveldt. But if you look at absolute complete success, meaning good vision, low pressure, and no complications at 3 years, 4% of the Ahmed made this grade, 11% of the Baerveldt, very similar. If we add medicines into the mix to bring the pressure down further at the 3-year period, 49% of the Ahmed FP7 had a qualified success, 66% of the Baerveldt, very similar as well. So then, we all understand in these very sick eyes that we are doing, there is a complication rate that goes without saying. Encapsulated blebs higher in the FP7, and suprachoroidal hemorrhages, retinal detachment, and choroidal detachment higher in the Baerveldt group. So then, we're looking for something different, something new, something to advance the ball forward. And I want to show you how we are doing our for Ahmed. So I'm doing this with the help of a scrub nurse, not with a fellow. Just to show you, we don't block. This is a topical anesthesia, intracameral lidocaine, and the patient got tetravisc before. This is lidocaine on a 30-gauge needle to blow up the conjunctiva and tenons, and we also inject some of the lidocaine posteriorly, so there's absolutely no pain. We pre-place sutures 8O nylon in the holes of the M4, and notice this is a water bath that the scrub nurse is forcing right when I'm putting the Ahmed in the pocket. We also keep the M4 very, very wet after we flush it, so it's totally submerged in water. And with this, it allows us not to stick to the tenons with an easy placement into the pocket. I use an 8O nylon on a 3/4 beveled needle so that it has very little risk of penetrating the sclera, and we cut it on both sides. You could see just 8 to 10 millimeters from the limbus is all you really need, and the M4 is situated perfectly. It doesn't move and stays just where you put it, even in small spaces. This is a little pearl for making a very beautiful bevel. You must put the tube right on the cornea and then cut it longer first, make sure the bevel is in the right direction, and then cut it again so you're perfectly happy with the length of the tube. Using a 23-gauge needle, we enter the anterior chamber, and notice here when I'm putting this in, I'm on the iris, I'm touching the iris. So what we do is through the paracentesis, fill up the chamber with balanced salt, and then push the tube straight through. It doesn't matter, in my view, if you're close to the iris, as long as you're not blocking the tube with the iris, but you must stay away from the cornea. This is a knot called the Trubnik knot, named after one of my old fellows who invented this. This is a way to secure the tube to the sclera so it doesn't move around laterally. And what we do is just make a very complicated knot. Do not compress the tube each time, making sure the pressure is soft in the eye. And therefore, we have an amazingly stable situation. I am using now clear cornea to cover my tubes. This is made by TBI. It is a half-thickness, split-thickness corneal graft, and it covers the tubes very nicely. We then trim it to shape so that at the limbus, very carefully, we make sure there is no opening and that there is no access for erosion over time. Once 2 sutures are made at the limbus, we trim the vision graft, and additional lidocaine now because we didn't block and we have to close. So this is additional 1% non-preserved lidocaine. And because the pressure in this eye was 48 prior to surgery, we filled it up with viscoelastic, and that is a nice cushion in the early post-op period when you note that the pressure is inordinately high. And then we just go ahead and close. Sean, you could just move to the next. Now let me show you in this chronic angle closure. Please play it. This is my fellow putting in this tube. This patient had cataract surgery, now having an Ahmed M4, but has total chronic angle closure. So you can't really put the tube in the anterior chamber because you'll hook the iris immediately, and if you force it, it will continue to bleed. So here we are putting it in the posterior chamber. The 23-gauge needle goes under the iris in the posterior chamber, and you can easily thread the tube. As you see here, she's doing very nicely, taking her time, placing it in the posterior chamber so you could see the tube under the iris, wiggle it a bit, you know that it's free, suture it down to the sclera, and continue. Next, please. So let me tell you our initial experience with the M4. We looked at our first 38 patients, and admittedly, these patients were very seriously damaged eyes. The age was 70, about half were white, half female, and half had open-angle glaucoma. And everyone had at least one prior glaucoma surgery, and many of them, many more. We started with a pressure of 32 on maximum therapy. Our follow-up now is 6 months on these initial eyes for 20.4 millimeters of mercury. There was a large range in pre and post pressures, but an admittedly very small, tight range at the first follow-up. The pressure change was significant from start, heading down over the last 6 months, and between 3 and 6 months, the pressure seemed to even out where they were quite similar. Now, regardless of the type of glaucoma, and we took all comers here, the immediate drop from high pressure to the first visit was in the single digits, with very few shallow anterior chambers. By the first week, the pressure had gone up to around 10 to 14. Within 3 to 4 weeks, the pressure had leveled out on somewhere between 14 and 11 or 18 millimeters of mercury in a really perfect range between initial and 3 to 4 weeks post-op. After that, the pressure started to rise to 3 months and then at 6 months, and between 3 and 6, they seemed to level out. We started at 2.9 meds, almost 3 meds. At 3 months, only 0.13 meds were used. At 6 months, 0.59, a really drop in the amount of medications. Early complications were not very impressive, and they were short-lived and limited. Late complications, including 2 patients with corneal edema who needed graft. We had 4 eyes with high pressures that needed further glaucoma surgery, and there was some tube obstructions, where about a third of patients had some type of complications in this series, the most being hyphema. And there were no threatening issues or in the late complication phase, and no one lost vision significantly. The tube can be placed nicely in the posterior chamber, nicely on top of an anterior chamber implant. And one of the beauty of this Ahmed M4 is that it can fit in very tight spaces and not cause any damage to any of the collateral tissue, sort of like this. And as you can see here, everything is left intact with nothing being touched at all, and I bet you wish you shopped here. So what is the best advantage of this tube so far? If it looks good on day 1, it'll look good at 3 to 4 weeks. Vision returns quickly. There's no high pressure phase that we noted, but a slow rise in pressure over time. All conjunctival sutures are out by 3 weeks, and the patients can often go right back to the referring doctor. The major advantage, and I think there's a little magic here that I don't really understand, is that the pressure remains low between day 1 and day 31, even in the midst of a huge hyphema. And because I never stop the blood thinners and always use this topical blitz anesthesia, a hyphema is not rare, yet the pressure does not go up. Pearls of placement, it's easiest if you keep soaking wet in a water bath. Take a stream of BSS following you with your scrub nurse as you put it in, and make sure you have enough room to place the plate. Issues for me moving forward is that the pressure starts to rise at 3 months. If it stayed at 11 to 14, it would be just amazing. But now we have to start adding medicine in order to keep the pressures lower in a certain percentage of patients, and that number we're still looking at. And there are still failures, of course, but tolerable. The question is, should we be putting mitomycin in the pocket to perhaps decrease the pressure slow rise over time, and that needs to be seen. So in summary, the M4 makes sense so far as it has a lot of advantages, especially in the early postoperative period. Longer follow-up, careful observation, of course, is needed to assure that we are continuing to benefit our patients and everyone involved. Thank you very much.
Yeah, terrific summary about the new implant, and thank you very much, Dr. Moster. I'd like to invite up Dr. Gedde and also our panel discussionist, Dr. Stephen Sarkisian, who's an associate professor at Dean McGee Institute, University of Oklahoma. Welcome, Dr. Sarkisian. And we'll try to open it up now and answer questions about the